Tonight we're going to be talking about low back disorders, and Dr. Morris has really been gracious with his time to agree to share with us his expertise in this field. And before we get into it, I just want to mention this book. Now, you may not tell you can't tell by just looking at this, but this is a book that is really, really big and bulky. And I remember about 2 years ago, Dr. Morris's son, whom I met in Tulsa here, he proudly handed me this book because he knew about what I was doing and what I was interested in doing, and he proudly handed it to me and he said, "This is what my dad did." And I have to tell you, folks, just the sheer bulk of this is the kind of book that chiropractors warn teenagers about against putting in their backpacks and lugging around because it can really mess with your back. And just an interdisciplinary book. It had all sorts of entries from MDs, chiropractors, different experts, all in the field of back medicine, and it was really impressive. Anyway, I just didn't do much with it. I mean, I was really impressed. I took it home and I went through it, but that was 2 years ago. Well, a year ago, I sustained a very severe back injury from my racquetball playing, and I had to be in major rehab for months and months and months, about 3 times a day, an hour at the very least of treatment. And really, that's when I came to truly appreciate the importance of back care and back medicine and how important the spine is. And I don't think we could have a better person to come and introduce and to really speak to us in lay people's terms, and also from his perspective as an expert in this field. Dr. Morris travels all over the world to teach about low back syndrome. So we are really, really privileged to have him on the call tonight. Now, just ask Sherry if you're ready to read his introduction.
I would love to. Yes. Okay. Dr. Morris, he is an internationally recognized non-surgical spine and extremity sports and rehabilitation expert. That's a lot to say. Lecturer and author. He is the director of a health clinic in Torrance called SIRST. So he'll probably tell us what that stands for during his presentation. And he has practiced there for over 25 years. He's also the professor of clinical services at Cleveland Chiropractic College in LA and a member of postgraduate faculty in rehabilitation at several chiropractic colleges in North America and Europe. And as David mentioned, Dr. Morris is the editor and the author of the textbook entitled Low Back Syndromes. And I know he's going to pull from that a lot with what he shares with us tonight. So we are very thankful that Dr. Morris is here and very much look forward to this presentation. Dr. Morris, are you there?
I am.
Okay, we'll hand it over to you.
Well, thank you very much. I would like to start off this evening by thanking 2 individuals for the opportunity to do this presentation.
Dr. Morris?
Yes.
You sound a little muffled. We're not hearing too well.
How about now? Is this any better?
This is better.
It's better? Okay.
Yes, it is.
Thank you. So I'd like to start off by thanking 2 individuals first. As he mentioned, my son Christopher Morris, who introduced me to Dr. David some time back, and then also to Dr. David also for giving me the opportunity for doing this presentation. And for me, I'm very fortunate in my work because my work is very much my passion, and to have the opportunity to share information so that it can help each of you, hopefully in your life or the lives of those you care about, is quite an honor. I am sorry that initially I was going to co-present this with my colleague, Dr. Ted Georges. He's an orthopedic spine surgeon. He had an emergency at the last moment and was unable to attend. He was going to discuss more about the medication side of low back disorders and surgical side, but I will cover those in a little less depth than he would because of his obvious level of expertise in the area. I'll cover some of it, which may lead to some questions, and hopefully that will be of benefit.
Dr. Morris?
Yes.
We might need a little bit more sound. I think it's still fading a little bit.
How about now?
Now it's better, yes.
Okay, let me try that.
That's good. This is better.
So I'll be relying heavily on my textbook that was previously mentioned, Low Back Syndromes, Integrated Clinical Management. This is a textbook that I started passionately in the year 2000 and required about 5.5 years of my life, and my wife calls it our fifth child, with all of the pain that a mother would understand and appreciate of the birthing process, but for, imagine, going on for about 5 years. And it was designed to resolve a problem, and the problem is that with regard to low back disorders and all of the specialists involved in healthcare regarding the low back, there has become so much knowledge, so much information, so much training that each specialist's own area, there is a full-time vocation just trying to keep track of what is going on in your own field. And as a result, I found that specialists tend to become more disassociated from one another and less aware of the changing standards of practice, the changing science, and standards of practice in each of the varying specialties within the spine care field. So my goal for my book was to be a bridge builder for the doctors, for the clinicians, the specialists in the spine field, and then so that they could then give what I would consider a better, more comprehensive approach to care for their patients and better communication with their colleagues. And so I would start my book. When I started my book, I was inspired by Aristotle with his saying that it's the sign of an educated mind that can entertain a thought without accepting it. I will give my perspective. I will tonight in the presentation. I will definitely editorialize because I have some strong feelings in certain areas, and I'll share some of those. And for those listening, you can then entertain it and decide whether you feel it's worthwhile or not. The problem of low back disorders is very interesting because it has not been historically a problem for humanity. It's not been a problem for societies. It's kind of actually a new problem, but it has now become a significant problem. It is, if we were to look at the costs for low back disorders in various Western countries, we would see staggering costs and increasing problem. Oops, sorry, here, let me just get back here. And,
there you go.
there we go. And we would see that the costs are continuing to mount. In the recently, certainly we've had this global problem, financial meltdown globally, and I think this has helped people to understand more about the integrative nature of our economies and issues that can come to light that can really have a big effect. President Obama has been talking about the costs of healthcare disorders, and I think in the past it hasn't been emphasized the burden that it can be. And when we talk about low back disorders, we're talking about the most expensive of the musculoskeletal costs and most costly disorder for musculoskeletal problems. It's generally number 2 in lost days at school and at work, and it's something that, and low back disorders tend to be something that is far more common among even children and adolescents than we had previously known, and very, very close in numbers and in prevalence compared to adults. And so, but there, and the costs that we have are not just direct costs, and it's very difficult to figure out what these costs are. In the first chapter of my book, I showed a comparison in two very well done epidemiological studies that included costs and showed dramatic differences in the estimated cost to societies. We know it's really expensive. How expensive, we don't know, because it's really hard to put those numbers together. what is interesting is that it may be that the direct cost, the costs for the doctors, the hospital, and all of the treatments may be just a fraction of the real cost, because it may be that the indirect costs may be 9, 10, or more times more expensive than just the medical cost, the healthcare cost. Why would this be so? Well, because of costs such as the person who, let's say that you have an employee who has a backache. Well, they may have lost some time from work, so you had to pay for their disability when they were off. Well, that's an indirect cost because that's not a medical cost. Now let's say that employee comes back to work, but they're really in pain, but they can work at modified duty. So you can get some production from your employee, but they can only lift, and they can only lift a portion of what they normally could, only do half the work. And so as a result, you're only getting 50% perhaps of the production, of the manufacturing, of the work accomplished, even though the person is back to work. And so when we start to look at the indirect costs, and we start to put those costs together, in addition to things like litigation costs, medical legal costs, administration costs for health care, well, then we start to see numbers that absolutely skyrocket, and these can be crippling to societies. Now, and then we can say, well, you know, that's kind of interesting from an academic standpoint and from a growth standpoint, but how about from, you know, a more personal standpoint? Well, I'm at 27 years in practice, and I have seen so many times where individuals who have had back injuries, and because of their back injuries, they lost their life. Actually, was just was really wrecked. It was very difficult to observe. They may have lost their job because of their work. Right. They may have lost their income. Times I've seen families really become destroyed. Divorces ensue because of the pain, because of the financial stresses, because of the emotional stresses, because of the loss of social activities and interaction. There are different cultures where, for example, men are historically the bread earners, and yet if they can't go and do the work, and maybe they're only qualified to do perhaps manual labor or things like this that required a strong body, a strong back, and they couldn't do that, then they weren't at all prepared to change their role with, for example, a wife who was then going to go and try to become the bread earner so that the husband could go and he could be cleaning the house and cooking. And so the stresses that occur, if we start to understand low back disorders and the problems that can ensue, is both from a cultural, a national, and international perspective is a problem. And then as we start to individualize the problem to just the person, the human, then we start to see that this also can be very, very, very catastrophic. And it's very difficult to observe these things, and it's why I'm passionate about my work, and my goal is to try to make sure my patients can understand these individually, many of these issues, and that students in my courses understand them, and that when we have the opportunity to discuss these things on larger scales or with employers, that they can look at other issues that are complicating factors, that as we evolve to a more complex society, that we can look at these things, isolate the problems, and it's through the education and through being proactive that we can understand and perhaps then resolve some of these mounting problems. And so in the first chapter of my text, I discuss some of these issues, and I say, as you see on your screen, that the national cost of low back syndromes are staggering, but the toll on the individual can be absolutely devastating, and it can be very sad to observe, difficult to observe. And so let's dig a little bit more into the problem and talk about the historical aspects a little bit before we then move on. So in the 19th century and before, low back disorders were really not much of a problem, and not very much was written about them. Only a few disorders really gained much attention. For example, scoliosis was a problem historically, and I show you a couple of illustrations. This is a variation of Hippocrates' rack that he would use to try to straighten a scoliotic patient's spine. And then Galen, another one of the most famous physicians through history, had another variation where they had dislocations of the spine or scoliosis, where they would start to work on them and they would try to stretch it and traction their back. And there were a few other conditions, musculoskeletal conditions associated with back pain, such as gout, that was known to cause pain. But for the most part, with all of the problems in history, back pain just is really not discussed too much. It really wasn't a big issue. This doesn't mean that we didn't have any back pain, but it didn't have an effect on the societies, the cultures, and it didn't seem to warrant a lot of emphasis in writing, even among medical journals, for the most part. It wasn't until really the 20th century when we started to see this start to begin. And so what happened, what led to it, and what led us to this problem in the 20th century, which is when we started to have a problem? Well, we note in the first chapter of my book, and the research has explained this, that if we talk about a natural history of low back pain, at sciatica, we would first think, if we looked at the research, that it shouldn't be a problem at all, because it tends to naturally resolve pretty quickly no matter what you do. And that means the symptoms go away pretty quickly in most cases, not always. And so you would think, okay, well, if it's fairly common for it to go away, what's the issue? There was in one paper by a fellow by the name of Cost and his group, they found that 90% of patients with acute low back pain recovered within 2 weeks. Well, first of all, it's one thing if you're listening to me and you say, well, 2 weeks and it went away, that's fine. But if it's you who woke up with the back pain, you had difficulty walking or getting around, you needed assistance to get up, and you were having difficulty sleeping, 2 weeks is actually kind of a long time.
Right.
So it is relative, and it's one thing that we in healthcare have to be always very careful about, is humanizing and really critically appraising the research and not just trivializing it. But even if we say, okay, if 2 weeks, after 2 weeks, most of the people with the pain go away after their experience, then that would seem as though it wouldn't be that much of a problem. But there is a problem, and the problem is that it tends to recur. Here's one of the approaches that might be seen from a doctor regarding the business of medicine, which we will talk about, and the business of healthcare. And this is a fellow, the doctor, who says, "Where you called me just in the nick of time, another day or two, and you would have been up and around." So this is something that we would say, okay, well, you know what? Why don't you just wait it out if it's only a little while, a little problem, and save yourself the doctor visit and the costs. But there's more to it than just a resolution and of the low back after 2 weeks, and then it's not a big deal. Because if that were the case and that were all there was to it, we wouldn't be talking about this. This wouldn't be the problem that it is. So what is the problem? What else is going on? Well, here are the problems. Problems regarding the low back is that it's one thing if it goes away, but if it keeps coming back, if it keeps recurring, that's a problem. And the problem is that recurrence rates are unacceptably high. Once the person has that first episode of back pain, they are much higher risk of having another episode and another and another. And they can become worse with time, more significant, and as a result, if they keep getting worse, then all of a sudden, with time, then it starts to become not just an acute or a short-term problem, but it becomes a chronic problem, a long-term problem. And we define chronic in different ways, but generally in the spine world we look at two descriptors for chronicity. One being 6 weeks after the onset of the condition. Other groups will say 12 weeks. And so somewhere between six weeks and 3 months. By the time you get to 3 months, there's nobody who's going to doubt that that falls within the heading of chronicity, or being a chronic disorder. And the problem is that chronic disorders are different in their nature than acute disorders. They're more complex, and they require different strategies. But unfortunately, the strategies for the back that seem to be beneficial in the early stages, which are the same types of strategies that you would use for any kind of a pain, almost, or any kind of an injury, where you try to rest it and you try to give it time to allow the body to heal it up. Those kinds of strategies for the acute phase prove to be detrimental, often for the chronic condition. Because for the chronic condition, and after time has passed, tending to allowing for too much rest and more rest. Well, I think I just need to rest it. If I rest it for another month, then I think then it should be better. If I rest it, oh well, it's not better, but maybe if I give it 2 more months of rest, then it'll be better. And what we find instead, that leads to deconditioning, to weakening, to changes in cardiovascular, but also lots of changes in the way we perceive our pain and the way we deal with our pain. And we'll talk a little bit more about that. So the complications of recurrence and chronicity start to dive together. They start to meld into forming this big problem. And the third part of the problem then becomes disability. When the person starts to lose their capacity to do their regular activities of their daily living, maybe their work activities, and all of a sudden now we've changed their lifestyle. We've put extra pressures on them. They have financial stresses, all of the stresses that we discussed earlier, and now it becomes a bigger issue because, you know what, it's not going away. My pain's not going away like it always did. I hurt my wrists when I was playing sports in high school, for example, or I sprained my ankle and I rested that and it went away, and I've had a few of these injuries or pains, and I rested them and then they went away. But you know what? This one's not going away. It keeps coming back, and I'm getting scared, and I'm losing sleep, and I have to do my job, but it's there, and I can't do it. And so these things start to magnify both in our body and within our mind. It's within this integrated system that make us the human, and then this becomes the base of the problem. And it takes, so we call it about chronic, recurrent, disabling back syndromes. This is what is the bane to the musculoskeletal world, to the emerging world. Now we're starting to see that as we start to become more, as emerging countries start to take on more complex structure, then the problems of chronic disabling back pain start to ensue and start to follow as they do in established Western world countries.
Dr. Morris?
Yes.
Would you say this is a Western thing, back problem, this recurring lower back problems?
Well, I think that we tend to, what we know based upon the research is it seems to have started there. But there's no evidence that back pain itself is new, and there's no evidence that the frequency of back pain is changed now compared to 100 years ago or 200 years ago. We believe that the amount of frequency of back pain is the same. What's changing is the recurrence, and especially the disabling back pain. In the 19th century, people were disabled by insanity. They were disabled by war and war injuries where they lost limbs. But they weren't disabled by back problems. And one of the reasons they weren't is because there was no social system to assist them or support them if they did. If they did have a back problem, it wasn't reported, and it was probably helped, and they were helped by the family. But even with that, it had to be a rare occurrence because there's nothing really reported. So what we see is as cultures and as societies have evolved to assist and protect the citizen in a different way than they used to, then as a result, the opportunity for disability has arisen, and this has been utilized.
Okay, because I come from a culture where we didn't even know what a chiropractor was. It wasn't until I came to this country that I knew what a chiropractor was.
Yes,
so,
well, these are not. There's nothing here that's chiropractic specific in our discussion here. But here's a quote from Dr. Mikheyev from the World Health Organization in 1993, where he gave a presentation to our World Federation of Chiropractic. But this is what is accepted generally, and that is with industrialization and automation, this has brought forward this epidemic of disabling low back pain. And we ask, well, what has caused this change, and what brought it? What things cause back disorders, or back injuries, or back pain? Well, we thought for a long time that obviously the person who has to do the heavier work, the heavier lifting, those are the ones who get more back injuries. That makes sense and have more disabling back pain, but there's evidence to the contrary now. At the time of the writing of my book, I gave one quote. I showed one study where they showed that in an emerging country, they found that the field workers had far less back injuries and disabling back pain than the office workers. And now there have been some new studies that have come in to confirm this. So and there's another study that came out of Finland. They have a large group of identical twins that they follow along and do quite a lot of research with. And they did a study regarding their back problems, and they found that the twin that tended to have a more physically demanding work tended to actually have a lower frequency of back disorders and back problems than the person who had less physically demanding. And for me, this made quite a lot of sense because our bodies are adaptable. And so the person who does more work, they should be stronger. They probably have better cardiovascular capacities with extra physical demand. So why shouldn't it be that their back would also be more adaptable? But this is not the way that it's been seen. It's not the way that it's been viewed, and it's still not. And so this is an issue that's actually in transition. And so if you speak with other doctors in the spine world, they may totally disagree with me. I'm not sure that they're keeping up with the literature on those things. I expect that with time there will be changes in NIOSH and other areas regarding work capacities and all of this down the road. But these are well-established programs and protocols with figuring out disability ratings and stresses at work and all of these. But I think that the research with time will lead to some changes in how we view these issues and what are the risk factors for these types of injuries. So let's talk a little bit about just some anatomy so that as we go through and talk about some of the potential problems and some of the ways that are some of the treatments that can be utilized to help you, that you understand. And you can hold on to these. I left these in your initial notes just so that you could look back at these to follow the anatomy. Oops, sorry. So we see here from a back view that we see that as we as humans, as bipeds, as we come up on 2 feet, we ask a lot of our spine. We ask our spine to be rigid when we choose it to be able to lift and move things and push things, and then we ask it to be flexible as we bend and we twist, and it's at our beck and call. And in order to be able to provide these mechanisms and these maneuvers in a safe manner is a rather complex series, but we need to be able to have load transfers coming up through our lower extremities, up through the pelvis, and transferred through the pelvic girdle up into the spine and across into the musculature. And if we were to look at the next slide, we see that the spine here can be separated into actually 4 regions. So we have the cervical spine of the 7 vertebrae in the neck. We have then going the downward in the mid-back where the thoracic spine, we see 12 vertebrae. And we see then below that the lumbar spine with 5 vertebrae. And then below that we have the sacrum, which is, if the center illustration shows you a triangular-shaped bone. And actually then we could even add one more a little at the tip, the tailbone or the coccyx, which has some small separate segments also. And you'll see on the left illustration that on the left side, that shows really the front portion of the vertebrae, and whereas the back is on the right part of that illustration, you have the spinous processes or the bumps that you would feel and palpate along your spine. And so we'll probably have you refer to those as you need as we go farther along. And here we can look at at 2 vertebrae from a side slice view, slice down the middle, looking from the side, and we see the front part of the rod vertebra, the block above and below each of those would be the individual bodies of a vertebrae, with then the attached back part of the vertebrae as you move off to the right. And then that spinous process, again, that bump you feel on the back to the far right of the illustration. And sandwiched in between the 2 bodies of the vertebrae is this intervertebral disc, which is made up really of 2 main components. It has a gel in the center, somewhat of a gel, called the nucleus pulposus. As we age, it dries out, and it tends on to take more of the consistency of crab meat. And then we have around that, we have this fibrous ring that we call the annulus fibrosus, and concentric rings around that central nucleus. And then if we move on to the next slide, you'll see that we have a top view looking down onto the body, onto the vertebrae. Again, you see the body, which would be at the top now on this illustration A, and that would be moving towards looking towards the front part of the body as you move upward. And then that spinous process, that bump that we feel on the back, is downward. And then you see we have side processes. And what I'd like you to especially call attention to here is you see this center, almost triangular area in the middle. That is the area that's called the neural canal, and that is the canal where the spinal cord moves down through. And there's many functions for the spine, but one of the most important is that these concentric vertebra, these vertebra as we move down the spine, all have this opening, and they all form this, with this neural canals, this protective bony protection for the spinal cord. And then you also see that if we move down to illustration B from the side view again, that we have on this transverse process on the side, that process is moving out to the side, and down just below that you'll see it says inferior articular process. So we're going to talk a little bit about some of the disorders that can be affiliated in each of these regions so you can understand what we're talking about. And those processes, that is, that we essentially have between 2 vertebrae 3 different contact points to form 3 separate joints. So we have that body in between the 2 bodies of connecting vertebrae. We have the intervertebral disc in the front, and in the back we have 2 of these articular processes, one on each side. And you can see also compare that with the illustration above, A, and you see these processes. And this is where we have these 3 joints, one disc in the front, 2 articular processes in the back part. And this is critical for your understanding as we move forward. So let's talk about...
Dr. Morris, I think the speaker, either your phone, are you on speakerphone?
No.
By any chance? Okay.
I have a handheld.
Oh, okay. Well, it seemed like it faded again. We're getting some comments from the audience saying that your voice is fading again. So I don't know.
I could switch to hands-free and let's see if it's better. How's that?
Yes, let's see that.
How's this?
Oh, this is much better.
Oh, this is much better? Okay.
What do you think, Sherry?
I agree.
Okay, it's fine with me.
Great.
Okay,
Thank
so
you.
let's move on now. Let's talk about some of the things that can go wrong with the back and how this can affect you. So the intervertebral disc disorders. Prior to the 20th century, the intervertebral disc was not considered to be clinically important. But up in 1934, two of the most famous spine surgeons in history by the name of Mixter and Barr, M-I-X-T-E-R and Barr, B-A-R-R, found that a disc, because of that gel in the center, that could cause a herniation, could herniate out, and that it could compress on a nerve and cause sciatica. And with that, we went to the dynasty of what we call the dynasty of the disc. And the disc became from nothing of any clinical importance to a major area of importance in the spine world. And the spine world continues very much to center much around the intervertebral disc today. So, and there's now, we really think of the disc in two types of disorders. So one, we talk about radiculopathy, which is the more clinical term for a sciatica, which means that you have a radiating pain. Pathy means something is pathological or it's a disorder. And it radiates down and it follows the nerves down into the leg in this instance. Or you may also have pain arising from the disc itself, because we've learned that there are nerves within the disc itself, and so that also may be a pain generator. The disc itself can be the part of the problem and the pain generator. Or it might not hurt, it might instead cause a herniation, which will clarify a little bit more, compress on a nerve, and then the person doesn't feel back pain. Sometimes with a disc herniation, you feel no back pain, and all of your problems are in your leg because the nerve is compressed in your spine, but it's not sensitive. You're not getting a pain sensation locally in the back. So here is an illustration of the disc, showing, this is from the disc chapter in my book, showing these concentric rings around the center nucleus. And so what can happen is you can, through injuries, through life, you start to get tears in those rings, in those fibers. And as it happens, then that gel can start to protrude backwards towards that spinal cord and towards the nerves that exit the spinal cord to innervate our body. And in our low back, that tends to then go to the groin, to the pelvic region, to the legs. This is a couple of slides from my book, and these are magnetic resonance imaging slides. So if you recall from our anatomy before, our brief, very superficial anatomy lesson, you saw the side view of the vertebrae, and you saw also the disc. And what we see on the left illustration here is a lumbar spine in which there is a significant disc herniation. So what you see is you see three fairly normal discs between the vertebrae up above, and also you'll note they're lighter. And this suggests that they actually have quite a lot of water content in the disc. And then the two lower discs are darker, with the upper of those two having something moving backwards, and that is a disc herniation and a rather significant one. And so that's pressing back into that area where the nerves are, into that neural canal that we talked about, and this can lead us to a very significant sciatica. And then you see on the right illustration, that's another MRI view, but that's what we would call an axial view, and that's looking down upon the spine. And this is the beauty of these advanced imaging techniques such as MRI, is that it can help us to go and see what's going on without having to do any cutting in to see it. And that's in many ways good and in some ways bad, which we'll talk about a little bit later. But we see there's a disc herniation, and this is harder to see. But essentially, if you notice the illustration that we showed you, there was A and a B. Previously, I'm not going to go back to it, but you see that the body of the vertebra was at the top, and that the disc was in between the two vertebrae. And so what we see now is that that there's a disc herniation that has protruded, and it's protruding to the right side into that canal, into that neural canal, and it's actually protruding both there and enough to the right so that the nerve where it exits is going to be compressed. And nerves do not like compression. They're very sensitive, and they don't handle compression well. And because when we look at these views in radiology, we look at them backwards, we would see this, and we would say that even though it appears to be on the right side on the illustration, because it's reversed, it would actually be, we'd be looking for a left sciatica type of a disorder associated with this, and see if that tied together, if it correlated. One of the problems that we had in the 1980s, and it's still to some degree a problem, is that when we started this new technology of computerized tomography, CT, which preceded MRI, it helped us to see these views, and all of a sudden there was a massive increase in spine surgery rates, because patients that had leg pain, all of a sudden we could see that they would have disc bulges in their spine, and it was assumed that that was the cause of the leg pain. And then it wasn't until after many, many surgeries over several years that they did a few studies on patients who never had backache and never had back problems. And they took, like, for example, studies from kidneys, and they just happened to look at them and found out that actually quite a large percentage of the population have disc herniations, and somewhere maybe a third and even higher, depending as you start to filter out your patients' base. In other words, maybe they'd be older, maybe specific types of their gender or specific types of occupations. All of a sudden, you start to find higher and higher rates of disc herniations among people who've never ever had any back symptoms at all. And so we had this problem of a lot of failed surgical backs, and the reason was because we hadn't tried to figure out what was normal, and we started doing surgeries on patients before we understood what is exactly normal anatomy. And the fact is that if we have 100 people listening to this presentation, there's a good chance that a third of you have disc herniations in your back. Actually, I have 3 levels in my own back, because I like to show my own MRI when I'm teaching, because I have a few levels of disc herniation both in my neck and my back, and I have no pain or disability. So one of the key lessons that you should highlight here is it has to be clinically correlated, the problem and the findings, and not to over-rely on the pictures, on the photos, just because we can see them. It has to be clinically correlated. So we'll talk a little bit about approaches to treatment afterwards. Right now, we'll follow the formatting of my book, which talked about kind of the problems and then what we can do about it. Another problem, and this is something that's going to be that is gaining and will continue to gain prominence in, at least in American society, well, I would say also European, because of the baby boomers, and that is spinal stenosis. Spinal stenosis means essentially that there's a narrowing of that opening, that neural foramen I showed you, where the spinal cord moves down through, from the brain down through, and then also where the nerves exit from the spine at each level. If there's any kind of a closing down and narrowing of that canal, then the nerves can start to get choked off. So they can be compressed by a disc herniation, as we discussed, but sometimes there will be degenerative changes that will occur. Some people have congenitally narrow openings, means they're born with narrow openings and they don't have much extra space anyway. Other people have very wide openings, very large openings, and they can accommodate a lot. It just depends. And so, but because it tends to be, spinal stenosis is associated with aging and the degenerative process, we see increasing numbers of patients with spinal stenosis. And so I thought I would share just a few issues. Let's see, I'm going to go back here. With spinal stenosis. Spinal stenosis, because it tends to choke off the nerves a little bit, there are specific symptoms that a person gets, and it's not so much of back pain, but of what we call claudication. Claudication is what happens when a person starts to kind of go lame. And so because it's from the nerves being choked off in the spine, then we call it neurogenic or nerve-caused claudication. And so a patient will, what they'll feel with spinal stenosis will not necessarily be back pain, but as they're up and they're walking, they start to feel that they're kind of going numb or getting some aching in the low back or the buttocks or the thighs, and it kind of starts to work its way down their leg or both legs, depending. And that they'll find that there are positions that seem to really help them and positions that really provoke. And so they tend to bend forward a little bit at the waist, because as they bend forward a little bit at the waist, it tends to open up those canals, that opening a little bit, and takes off some of that choking effect on the nerves. So people like to sit, and they like to bend forward. When I have patients, the question that I like to ask them, if I suspect a spinal stenosis, I'll say, well, what happens if you go to the grocery store? Can you only, because they'll say, well, I can only walk for about 5 minutes, and then I really have to sit down. I say, well, what if you go to the grocery store and you use the shopping cart? They say, oh, if I go on the shopping cart, I can walk and I can do all my shopping. It's not a problem, because they've unloaded their spine and they've also bent forward as they rest on that shopping cart. And so it's nice to have those types of confirmatory histories, because it really, by the time we finish our initial history, our examination really becomes just confirmatory. And so spinal stenosis is something that we'll see, continue to see in increasing numbers, and it can be responding very well to both conservative means, although at times it requires more aggressive procedures such as surgeries. We'll talk more about that. Now, Facet syndrome, I wanted to point out previously with our anatomy lesson that they had those joints in the back part, those two joints, those articular surfaces, and those have a nickname. They're called the facet joints. A true anatomist bristles at the term, but clinically it's been used for 100 years, and spine clinicians accept and understand what it is. It's these two little joints in that triad, that complex of the intervertebral disc in the front and the two facets in the back. And where the two vertebrae come together at the facet joint, there's a little, what we call a joint capsule, a little cartilage in there with some fluid in it and chocked full of pain sensors. And when those get inflamed, it can be extremely painful, and it hurts the patient. It really does not like bending backwards, because it provokes their pain, and at times, especially bending, if they just have a inflamed facet on one side, maybe on the left side, if they bend backwards and to the left, they're compressing it. And compressing that irritated facet will be very, very painful right in their back, and also it can extend. And we did a very nice chapter with one of my colleagues on these types of disorders. And this is the illustration from the book that shows that it doesn't have to only be local to the low back, but it can actually extend along these types. You see on the right the abnormal distributions. A lot of times patients are under the impression that if you have pain in your buttock, or if it goes into the thigh or a little farther down, that it has to be a nerve root compression and it has to be a sciatica. But there's lots of other things that can cause. There's other things that can cause pain going down there, extending down, and it doesn't have to be compression on the nerve. And so if you get a really inflamed and really hot facet, you can get these types of pain distributions as we demonstrate here. And so very often, and I end up correcting a lot of my patients because they've been in a way, I'd say, misdirected and a little bit stigmatized, a little bit freaked out because of their sciatica going into their buttock and things like that, but there's no evidence that they have any compression of a nerve and that the sciatic nerve is not involved at all, but instead that there's other things such as perhaps facets that are causing their pain. And these don't tend to be major surgical problems. Their life is not at an end, and I must calm them down and reassure them and then prove it to them because they've become so convinced that they have, a true sciatica, and that life is lost. And so facet syndrome is very, very common. I see it every day in my practice, and they can respond to a variety of different. It can respond from a variety of treatments. What's important is that the clinician has the skill to be able to isolate it and differentiate that from other diagnoses and other conditions. And very often I find that that's missed. So these are the types of issues that can be discussed. And I think we also need to be fair and reasonable in our expectations. Let's say that the clinician that you look to is perhaps a family doctor. Well, the family doctors must be so broad-based in their knowledge that we can't expect them to be an expert in every field, including the spine field. And so very often things can be stated that they've been taught in order to look at something rather superficially and to give a trial of treatment, because what they'll give maybe is perhaps a trial of medication or something, and whether it's whatever the pain generator doesn't matter that much, and because they'll give a medication, and whatever's hurting and whatever's inflamed, it'll hopefully address it. So I think what you have to be prepared to ask the questions, and you also have to be prepared to be reasonable in understanding the degree of experience in your clinician. And the more you can ask the questions, the right questions, and partner up, and hopefully the more that your clinician will be straightforward in their level of experience in a certain area, so that you are getting a reasonable amount of information based upon their skill and their knowledge level. And so very often we see patients who are too intimidated by the doctor to be able to ask the questions that they need to ask to really understand what is this clinician's skill in this area. So the more knowledgeable you can be, and as Dr. David said when we first started, the more you're forearmed to be able to go and be able to really make it a partnering experience with your clinicians as you understand what's really going on. So one of the key rules I would like you to hold on to is just because you have pain in the buttock or to the thigh does not mean you have sciatica. Another one of the areas I'd like to emphasize is the topic of myofascial pain. Myo means muscle. Fascia is that thin, tough stuff that you cut off when you're cutting meat because it's gristly. But the fascia is this sheath around our whole body that helps hold us together. But it also, not only does it hold us together, but it has lots of sensory nerves in it. And so when we talk about myofascial pain, muscles can cause pain. They can cause problems, and so can that covering, that fascia, and that integrates with muscle. It's all tight together. You know it by only trying to cut it away from the meat that you want to eat that's not so gristly, and you see how integrated that it is. And we have to be very thankful to the grande dame of this topic, Dr. Janet Travell. She was a medical doctor, went to medical school in the early part of last century when few women were able to get into medical school, and she became very well known in helping to bring myofascial pain and this topic of pain to the medical world. She became renowned in her writings and in her teachings, and in fact she was President Kennedy's physician while he was in the White House. And so myofascial pain, essentially, if you felt knots in the muscles that are painful and tender, we call those a type of myofascial pain that we call a trigger point. And trigger points can cause pain right at the local site where they're located in the muscle, but at times this is another thing that can cause pain at or symptoms or tingling at a distant site. And what we have, excuse me, what we have is really now a very well logged series of mapping of typical trigger points in each of the muscles of the body and typical referral points. And we've documented many of these in my textbook in the myofascial pain chapter. We could talk about any of these subjects for hours and hours and hours. Our myofascial pain chapter is rather complex, but and the causes of myofascial pain are still, we know a lot, and there's still much we don't know, like on all of these topics. And like all of these topics, there is controversy in all of the topics. But this will show you that some of the muscle, two muscles of the pelvic area. This is the in the hip, the gluteal muscles, the gluteus minimus and medius that are on the, that help us to bring our right leg out to the side. They can get trigger points in them, as can all skeletal muscles. And what you see is where they can be located in the two left, by the X's in the two left illustrations. Well, actually all of them, all the way across you see the X's. And then you see where they tend to refer pain to. And so a person may have the problem in that muscle on the side just above the hip joint, but they may be getting pain in the buttock, or they may get it in the side of the thigh, or they may get it in the side of the calf. And that instead of just treating locally, what the clinician needs to be schooled in and understand how this may be, the more you study and understand the typical pain patterns of the muscles, then the more you can start to isolate maybe where that pain generator really is located. And there are a few things that I would just like to say with regard trigger points. One, what causes them? Well, historically, we've always talked about if a muscle gets overloaded, is too heavily worked, it can get these knots. And this is clearly true. But there are other factors that can lead up to the trigger points, to the knots, and to the pain that's affiliated with it. First of all, the person who, the thing that I like to look for with a person that has these kinds of knots, and I suspect this may be part of their pain, is if they don't like cold breezes. I have lots of patients that will come in and say, well, yeah, I got a cold in my hip, I got a cold in my shoulder. Well, actually what they're telling me is that they have trigger points, because trigger points are provoked by cold breezes, and they tend to be nicely relieved by heat. So these types of patients love to spend a little extra time in the bathtub or in the hot shower, because they feel much, much better, because what happens is then the circulation and the muscle changes, the muscle warms up, and this tends to cause the trigger points to be temporarily relieved. Sometimes it can be for quite a long time. Maybe it'll feel better for days or weeks until the next time that muscle is provoked. You sit in the wrong position, you get a cold breeze, and then it comes back, but it keeps coming back, and it's a recurrent problem. We find at times that nutritional issues can be critical issues in chronic trigger points, chronic myofascial pain. For example, if the person is low in vitamin C or B complex, some of their minerals such as calcium, magnesium, potassium, these also tend to have an effect. Because they have an effect on the way muscles contract, they have an effect on the way trigger points and the nuts in the muscles tend to form. So I'm very big on these patients especially, making sure that they have some proper nutrition, because otherwise I can keep treating them, they'll feel wonderful, and then it will recur. So those are some of the more common causes of low back disorders, low back syndromes. And one of the other things that I wanted to clarify, though, is by the time a problem becomes chronic, it is rarely any one of those problems, but some sort of a combination. Students very often change the way they walk, they've changed their posture, they've changed things, and if it may have started off with one area or one type of a pain generator, by the time they become chronic, there's very often multiple causes. And so very often this requires a little bit more complex thinking by the clinician, by the patient, because it requires a multi-stemmed attack or approach to take it on. And the more that you can be aware of it, the more you can ask the questions, the more you can partner and team with your clinician or clinicians on this, then the more better chance I think that you'll have of resolving the issues. So I'm a chiropractor and proud to be one. And so I heavily rely upon manual therapeutic techniques. I use many combinations. I'm a little bit uniquely trained in my field because I've had quite a lot of training in manual medicine and rehabilitation from Prague, from the Czech Republic at Charles University Medical Hospital. And so I have brought a number of these techniques to my profession and to other spine clinicians, such as physical therapists and athletic trainers. My feeling is that we must work together as a team for our patients' benefit. And I come across colleagues in each specialty that at times feel as though they may that it's only a competition, but it's for the patients that we serve, and those are the clinicians that are of like mind that I enjoy working with. And I think that that my patients benefit by the clinicians also who are looking to work together and team up for the sake of the patient. So I'm very interested in manual techniques, whether it's manipulative techniques, because one of the other areas that can be a problem is certainly the joint that becomes dysfunctional and locks up. Historically, we've used the term subluxation, and if those of you that have been chiropractic patients may have been told by the chiropractor that the problem that they had, or at least one of them, was subluxation. There are a number of terms, but essentially what we're talking about is the joint has lost its normal function, and that very often some of its motion, and that we can use a number of techniques, whether it's manipulation, mobilization. There's many, many techniques and the goal is to restore that function. We also use manual techniques, though, also to normalize the muscle tone and the function and the length of the muscles to reduce. You can use manual techniques to reduce the trigger points. I use different types of mobilization techniques for spinal stenosis and also for disc syndromes very, very effectively. I have very few, I see a lot of sciatica patients, but I don't send very many to surgery, very, very few. And and whatever successes I get always mean that I can accept up to 50% of the benefit, and I accept 50% of the responsibility, because my patient has to accept the other parts, because what they do, both coming in to see me and then what they do outside the office, can lead to the success or the failure of our approach. So the manual techniques now, manual therapeutic techniques have now become very accepted, and the research behind them is very, very strong with regard to both low back pain, and it's improving with regard to conditions such as radiculopathy or sciatica. There is growing evidence. It still needs to be improved, and there's a lot of questions still that remain, but my general feeling of the way that the research is taking us and the success rates shows us that it'll continue to be increasingly utilized for sciatica types of disorders also. Let's see. We have electrotherapeutics. There's so many of these we could spend hours and hours talking about them. I would say historically we've used a lot of modalities, we call them, such as ultrasound, which can reduce some pain. We use different types of electrical stimulation to cause muscles to relax, to improve the way the muscles contract. Probably the most interesting new information and research is the use of lasers, cold lasers and even some warm lasers that seem to be effective in reducing pain and helping some of these conditions. And the one thing that has been shown to be effective both in prevention of back disorders and also critical in whatever it's combined with is exercise as part of a treatment strategy. Right now, if we were to be very specific and read the literature, and the majority of the literature would say it doesn't matter that much what type of exercise you do because they haven't been able to prove one is more effective than another. But I will tell you in my approach that there are faults within the way we defined back disorders, and I believe strongly that with time, the more we learn about each type of specific back disorder, then the more we'll find that specific exercises will be effective. I'm very selective in my exercises for the cases that I get, although most of the cases I get are chronic and complex. But I believe that the specific exercises are critical, and so do many of the, well, I would say all that I can think of, all of the what I would call higher-level spine experts that use manual rehabilitative techniques, is they use specific exercises. But if we were to talk about what the level of evidence-based medicine today is, they would generally say that just do exercise that's tolerable, and there is benefit to that. Medication is something that I'll speak about only briefly. It's not my field, and I have no training in pharmacology. Although I co-manage many patients who are on medications, and I do caution them regarding medications. Most commonly, I just warn them about the use of non-steroidal anti-inflammatories, NSAIDs, where they have them that are prescribed by their prescription, and then those that are over the counter. And what the important thing that I try to make sure my patients understand is that it is a type of acid, and that it is something that, because it's sold over the counter very often, patients think that it's safe to use it forever, but we have very well documented thousands of patients dying per year from overutilization, generally older patients, generally geriatrics, but somewhere in the neighborhood in one paper it talks about 15,000 deaths per year associated with the use, the overuse of non-steroidals such as Aleve or aspirin or some of those, because they tend to cause ulcers. And so the only things that I tell my patients is that, one, make sure that you always take at least 12 ounces of water with them to dilute them, and don't just take that pill with a sip of water and turn it into an acid paste. It's a bad idea. And to make sure that they discuss the risks of long-term use with their physician if the topic hasn't already arisen. There are many other types of other medications from the steroids. Steroids, which are what could be considered a stronger medication, and also even stronger morphine derivative medications that have been extremely, there's been a dramatic increase in their utilization in the United States in the past decade. What I would only say there is, based upon the research and the complications that we're seeing, that the patient should really have a lot of questions and should make sure that their doctor is clarifying the risk factors for taking these for the short term and for the long term, so that whatever approach you take, that you really are making informed decisions on the use of the medications. And since I'm a conservative care provider, my goal is to keep my patients off of medications, to keep them out of surgery and all of these areas. But on complex cases, I thank God that I have those specialists to refer these patients to or to work with in the cases that I'm unable to resolve them by myself. And this is the way that it should be. As we have these more complex conditions that require more multifaceted approach to care, what we want is the clinicians that are prepared to team together and work together. And I'm so happy in my area, the specialists, the spine surgeons, the pain management specialists, the physical therapists, the acupuncturists, the family practitioners, the rheumatologists that are in my area that I have as resources to co-manage cases with, because nobody can do everything. And so this is the key, and I think my patients benefit from our teamwork.
Well, I was going to ask you about, knowing that in many cases tenuous relationship between chiropractors and spine surgeons, and I was like, how does that work? Both of you working together in the same clinic, because it's unusual.
Well, I would say it's becoming increasingly common, and this is because we share a common bond of science base in our training and a common care for our patients. And so we see now that there are spine centers around the United States. For example, I have a colleague who's involved at Harvard with their big multidisciplinary center there, which has gotten quite a lot of national notice. And I have colleagues in New England, in Canada. The Texas Back Institute is the largest private spine center in the world, and they've had chiropractors as their primary access clinicians now for more than a decade. We have there are increasing numbers of co-management approaches because the research and the science and the concern for the patient is what drives us together. What the problems generally is, in my view, have to do with the associations. You know, people tend to think of healthcare associations as the ones who protect them the most. I don't feel that way. I think that more than anything, they should look at each of the healthcare associations as unions that are designed to protect their membership. And so very often, but they have an awful lot of clout with regard to impacting public perceptions. So there's, and then it varies internationally, Dr. David. For example, in Great Britain, the Chiropractic Act was passed there last decade, and it was brought to the House of Lords actually by Princess Diana, and it was supported by the British Medical Association. They were all in favor of the chiropractors coming and having official laws. And so we see different countries with different relationships, and very often it depends on the history and perhaps a positive or a negative history. But as far as I'm concerned, it all comes down to the patient. And so, and when you find more and more clinicians who are aware of the research and are respectful of the research, and they see their patients benefit from a given type of care, and they see that it's professionally performed and the person is aware of the research and the science, then this tends to promote respectful cooperation, and that's and the patient's benefit. So there's been historic differences, and there remain political divisions that I don't think are for the patient's best interest. I really don't, that continue. And so anything that we can do, I think each one of us has to do our best in this life to try to be a bridge builder in every way that we can. And when you have the right well-meaning groups, it's been my honor to befriend and to have professional collegial relationships with leading physical therapists, spine specialists in the medical field and chiropractic field around the world. And generally what I find is the higher level the clinician, the less they even worry about the trivia of some of those differences. They're aware of the politics, but they're aware of the quality. And I think that that's gradually changing things, and I think that patients, as they become more empowered, should have those expectations from their doctors to be you have to figure out if you want to be involved and co-manage with a pragmatic clinician or somebody who's perhaps not aware and not keeping abreast of other approaches that have been shown to be quite successful. So let's talk a little bit about minimally invasive procedures. This is essentially the area of the pain management specialist or the pain medicine specialist. They go by both terms. Pain management is more commonly known and utilized. Pain medicine is actually more technically correct, at least in the United States. But essentially what it is it's a relatively new specialty in medicine that was brought about by the anesthesiologists who found that they could use needles and they could use different types of medications to isolate pain and figure out where the pain generators were coming from, where is that pain initiating from, and also that they could also use injections and to resolve conditions. And so I was very fortunate to have Dr. Nedeljkovic from Harvard write the 2 chapters in my textbook explaining standards of practice. When that chapter was on how they go about using their needles for diagnostics, and the other how they use them for therapeutics. And so here, for example, we talked a little about the Facet syndrome as being a generator of pain, while on the left illustration here, you can see what they're doing with their needles or their different types. They also not just use needles, but sometimes they'll, instead of injecting medications, they'll use a little zap of electricity to take out a nerve that will then be dysfunctional. Without the nerve, you don't have the pain to that facet, for example. And then it takes several months for that to grow back, but during that time, they don't have any pain. They walk normally, they exercise, they get rehabilitation, and so they feel better. So they can use them for isolating that, that facet pain, or they can go and put a needle inside that joint, put some medication in there to reduce the inflammation, or they can, on the right, they can, instead of going to that facet, they can place needles within that neural canal for, we call it an epidural steroid injection. It's in that canal around where the spinal cord is and where the spinal nerves leave and exit at each level between the vertebrae on the sides. And this right illustration, both of these are from my book, and the right upper illustration shows different access points that the pain specialist would use in order to place generally what we would place in there as steroid in there to try to remove and reduce the inflammation within and around that area. So they'll use that maybe for a disc herniation with radiculopathy or sciatica, or they may also use it if you have a spinal stenosis where the nerves are getting choked. And it can be effective for either of those. I like all of these topics. There's those people who will have questions or doubt, but for the most part, they're commonly utilized in different areas, more so or less so. But it is now commonly, pain management, pain medicine is a very, very critical and established part of the spine world, more so probably in the United States than anywhere else at this point. But I think that that's gradually changing, certainly a lot down in Australia. And it just, but it is new technologies, and this group relies heavily on new burgeoning technologies and minimally invasive approaches to try to resolve spinal disorders. Surgery. I have a few patients every year that end up going to spine surgery. Not many, but a few have to, and I'm so happy to have the excellent spine surgeons that I know and work with to refer my patients to. And very often I'm one of those because of my teaching, but you know, all of this ends up coming down to one's own curiosity. And so I made it a point long ago that if my patients went to surgery and I referred them to a local surgeon, that I would be there at the time of the surgery, because that was part of my continuing education, and I felt also an obligation to be there. Generally, patients would be a little nervous before the surgery, and chiropractors tend to have very close relationships with their patients because we tend to take more time to educate and explain things, and we are a hands-on profession. So to be able there and you know, put a hand on a patient's shoulder or give them a handshake and let them know I'm there has always been something that they found very appreciative.
Yeah.
So with surgery and spine surgery, there is only one real emergent time for surgery. That is, that's not traumatic. So that means, of course, if a person is in some sort of a car crash or something where they have fractures and there's trauma, they need emergent surgery. But outside of that, non-emergent spine surgery, there's only one condition, and this is a condition that we call Cauda equina syndrome. That's C-A-U-D-A, equina equina, E-Q-U-I-N-A, syndrome. And what this means is that there has been something that has caused a sudden and a significant compression on the spinal cord, the lower part of the cord. In the lower part of the spine, the spinal cord is called the cauda equina, which in Latin stands for horse's tail. And if you get a sudden compression on that and significant, then a patient can lose feeling in their legs, but they can also lose control of their bowels and their bladder. And this is something that can, if it's not decompressed in an emergent fashion, then they can be left with permanent loss of control of their bladder, or their bowels, or weakness of their legs, or inability to walk. So it's something that, if it happens, it's something that must have immediate surgery. Fortunately, it's very rare. But other spinal surgeries then become non-emergent, but that doesn't mean that they can't be of critical importance to the quality of the life of the patient. And so we talked about briefly the decompression of the herniated disc, which dates back to 1934 and is still rather common and very effective procedure on the patients. My favorite study ever with regard to spine surgery, though, was a 10-year study by a chap by the name of Weber, W-E-B-E-R, years ago. And it was a 10-year study, and what they did is they found patients who had were qualified to undergo disc decompression surgery for sciatica, for radiculopathy. About half of them chose to have the surgery, and half of them chose not to. And they followed them for 10 years. And what they found was that the patients who had the spine surgery were much, much better in their symptoms the first year. After that, those patients started to decline a little bit, and the patients who were suffering from the sciatica that didn't have surgery were gradually improving. And within a few years, the two groups met up, and they didn't find a big difference. And so essentially after 5 years and then 10 years, they're essentially the same. So the general feeling has been among many, including myself, that if you can't tolerate the symptoms, if it's too much of a burden in the quality of your life that you can't go on, then you should really strongly consider the surgery. But if it's an inconvenience that you can live with, then you should see if you can't wait it out, because there are various approaches that can be utilized, and as they call it, the tincture of time, that you may be able to avoid it. I'll give you another critical piece of research that had a big impact on me, and this actually came out of 1954 in Sweden by a fellow by the name of Professor Carl Hirsch. And his assistant was a guy who became the most famous spine orthopedist in the world at that time, by the name of Alf Nachemson. And these two, what they did is they studied a bunch of pilots who were just learning about flying in jets, military pilots, and learning to land on battleships. And at that time, jet engines were new. Landing on battleships was really, or on aircraft carriers was a new skill to be learned and exciting, and they didn't have very good shock absorption at that point, and so a lot of them were landing very hard and getting crush injuries to their spine, requiring emergency surgery to their spine. And what they found was that within 6 to 8 weeks, all of them were back flying. And what was striking about this is that Nachemson did then a 50-year retrospective study on all of these now geriatric surgeons, the pilots, and found that they had all completed their tour of duty, and they went on to lead very active, healthy lives. And so what he shared in his knowledge was that what these people all had in common was that they were passionate about flying, and it was the most important thing in their life. And so they couldn't wait to get back to it. So despite the trauma, despite the surgery, because they were motivated to get back into the cockpit and get on with their life, they did.
Their bodies basically responded to their desire, huh?
That's right. And so this led us to, in the past decade and a half, what we call the sports medicine model of rehabilitation. And that is, if you've ever been involved in a sport that you were passionate about, you found that you couldn't wait to get back, and you even went back in while you were into the sport while you were still hurting, and then you were so focused on the sport, on the team, on the winning, or whatever, that pretty soon you found you were fine again. And that very often when people have back injuries, they're afraid of the back injury. They're afraid to go back to work. They're afraid to do activities. And as a result, they become more deconditioned and they focus on the pain instead of the game. So we see in the United States is the champion when it comes to spine surgery rates, and more recent papers than this one actually show that it's spotty. Some areas in the United States are 10 times higher than other areas in the United States based upon the local surgeons, their impact on the area, the medical community, if it's a learning center. And unfortunately, we find that spine surgeons, the busier they are, doesn't equate to better results. You'd think that the more they do, the more expertise they have, but that doesn't occur. So some people feel as though the reason is that they may be not as selective in the cases that they choose to do surgery on, and as a result, they don't get as good of results. So I generally tell all my students and all of my courses that the most important modality of treatment that I provide is patient education and counseling. Now, many chiropractors would probably tell you that it's their adjustive techniques. Others, clinicians, depending on what it is they do, it may be their exercise, their medication, their procedures that they perform is their most important. But for the most part, it's how we teach our patients, how we explain things, and how we direct them to and inspire them to become more independent and more proactive is what I consider the most important thing that I can do for my patients. And with regard to rehabilitation, which is a very big part of my practice in sports work and in post-surgical rehabilitation or post-injury rehabilitation or chronic pain rehabilitation, there is emerging evidence of techniques that help us to improve the functional stability of our spine and to be able to handle loads more effectively and to protect our spine. Whereas the last century, a lot of the concerns, and still to a good degree, many concerns, people are concerned about having too much pressure, compression on their discs. The fact is the discs were designed to be compressed and have pressure on them. The problem is when what discs don't handle well is torsion or shearing types of loads. They don't do well with that, but if you put compression where it holds together very nicely and tightly so that the load can go straight down from one bone through the disc, for example, and to the next bone, they do quite well with that. And so there's an increasing level of interest in functional stabilization, we call it, and there are different ways that that's accomplished, and that's a big part of the passion of my work. My professor from Prague, the late Vladimir Janda, Professor Vladimir Janda, was a leading authority in leading the way. In the 1980s, he was talking about this functionally unstable low back, way before anybody else was talking about this and going around the world to explain the importance of it. And he talked about it in 1985 that these muscles of our low back, of our lumbopelvic area, these include the diaphragm and the pelvic floor musculature, that these help to form a corset, a functional corset to protect our joints and give us functional stability. Many people think that chiropractic is just based on manipulative techniques, and they tend to think physical therapy is exercise. But before physical therapy was even organized as a profession, this is a 1902 photograph of Dr. B.J. Palmer, whose father was the founder of chiropractic. This is his rehabilitation clinic in Davenport, Iowa. And so and there was no organized physical therapy. So I discourage people thinking, categorizing different professions into different boxes. Instead, work and understand the specialist, the clinician, and what their area is and what they can provide to it, and what other areas they feel that they can team up with if they need to.
Right.
This is another one of his exercise device with a pulley system from 1902. This is a patient of mine from last year. This is Ladislav Nagy. He was I work with hockey players. He was with the LA Kings, and he had a disc herniation in his neck. I was in the middle of this is at the Kings Training Center actually, and he had run out of options clinically except for a spine surgery, fusion surgery, because of pain in his shoulder and his shoulder blade and his arm. And I used a emerging technique out of Prague that we call dynamic neuromuscular stabilization that successfully resolved his condition, and he's playing professional hockey again this year. That never would have happened if he would have had the surgery. So we saved him a surgery and kept him in his profession. So there's lots of new and exciting approaches that are going on. I'm very happy to be where I am in my profession, my work, and having a chance to go around the world and share this, both locally with my patients, but around the world with other clinicians to help bring this together and bring the spine world together for the benefit of the patients. I'd like my final, second to last thoughts are those of talking about the postural system. This is a system that we don't generally think of when we go through our healthcare training. We tend to think of cardiovascular or musculoskeletal systems, but the postural system comes out of my training from Prague, and here we talk about what is this combination of systems that gives us our posture. And the posture, as the more we learn, the more important we talk about carriage and proper carriage and the adaptability of the postural system, and how by maintaining a youthful posture, you maintain your energy, your vitality, your conditioning. And in this country, we have not given enough emphasis on the importance of posture, maintaining a youthful posture to maintain our conditioning and our activity and our health. For example, and to show the adaptability, there was a study of the postural system, its adaptability, where we found that, for example, in cultures where the women carry things on their head from childhood, that they have less curvature in their spine. They have straighter spines as they've used the muscles of their posture, and by doing that, they maintained a straighter spine. And so we see the adaptability, and we want, sometimes I feel as though in healthcare tends to take us away from respecting our inherent capacity for healing and healing ourselves and maintaining our health and focusing on those critical issues. So I wanted to give this example as one where we show the adaptability of our body. And so in closing, and before we take any questions, my summary recommendations for you would include always, as Dr. David said, be proactive for your health. Accept the responsibility for your health. Too many patients, I think, tend to look at their health like they do at getting dinner at In-N-Out Burger. They are looking for a quick fix instead of understanding what causes the problems and what they can do to be proactive to protect themselves or to resolve issues. What can they do on their own? Focus on your posture. Maintain a youthful posture. Maintain a youthful mind. And maintain that active lifestyle. Don't allow things to interrupt that. Maintain that, because without the active lifestyle, this tends to also lead to increasing depression levels, which help to increase the complexity and the chronicity and the risks of disability. We didn't speak that much about the emotional sides of this, but it's all interrelated. The best quote, anybody who would think that we talk about a mind and body and that they're separate is wrong. And the best quote I've ever heard was years ago by a doctor who was both an orthopedist and a psychiatrist, had double specialty, and he said that the only way that you can practically separate the psyche from the soma, the mind from the body, is with a guillotine. Otherwise, it's all one, it's all integrated.
Right.
And so balance your seated and your standing activity. I see patients all the time who sit at work, and guess what they do with their breaks and their lunch? They sit. Instead, balance your activities. If you sit at work, stand during your breaks and your lunch and your other activities. Make sure you partner with your healthcare providers to not just be a passive member sitting in there and looking as though they are the know-it-all. If they don't have the time for you, then I don't think you should have the time for them. And when you're looking for, when you have a problem that's persisting, I suggest you look to more conservative approaches and then work your way back to more aggressive approaches, whether it's medications or injections or surgeries. If it's not an emergent issue, but take your time and make sure your questions are answered and have respect for your own questions, just as you should have respect for the clinician that you're consulting. It has to be a partnership, and you have to accept your responsibilities.
Absolutely.
And that's it. Any, Dr. David, or any questions? I'll be happy to answer.
Sure, absolutely, and thank you so much again for this presentation. It was very, very informative. I know we asked you before the webinar started, we wanted to know what the first, I know that's an acronym, FIRST, what your health center has called that. Could you explain to us again what that means?
Well, I looked at what it was that I'm interested in and the types of cases that I have, and the work that I do, so I just said, well, it's short for family, industrial, because we take industrially related cases, workers' compensation cases, rehabilitation, because that's my area of specialty training. A lot of people are unaware that there's specialties within chiropractic where there's postgraduate training and testing, board certification, and ongoing continuing education. Mine is in rehabilitation. And S is for sports injuries, and then for therapy, different types of therapy, whether it's manual or whether it's emotional counseling. I'm not a psychologist, but a lot of my work, as I said, has to do with patient education and counseling. And so once I started thinking about what it was I did, that led me to First Health.
That's fascinating. Was it in the book that you found that you mentioned the part about people responding a lot quicker when they love what they do or they love their sport? Did you have that in your book, or
I think it's in the last chapter.
Okay. Well, where can we find research like that in addition?
Well, I mean, as I said, that initial paper was done by Carl Hirsch and Alf Nachemson, and then Nachemson did the 50-year post. I mean, he's, as I said, he passed away 2 years ago. He was the most renowned spine orthopedist researcher in the world out of Sweden. The best spine surgery results that we have documented are out of Sweden, actually. And we think the reason is because they just screen their patients better. This is the problem is not the procedures. Manipulation is a good procedure, and so are most of the surgical procedures and the rehab. It's the right case, the right procedure for the right patient. It's the selection process.
I have a question from one of our audience members. What is your opinion of the compression therapy? I did that myself for my back. Is the research you are aware of positive? Generally speaking, is it worth the relatively high cost, in your opinion?
No.
No.
The research is it's traction. Traction has been known to reduce muscle spasm and inhibit pain for a long time. And then what happened is a few years ago, in my view, there was a very wise, from a marketing and financial standpoint, the term decompression that was used by the spine surgeons was then brought in. They had some computerization to traction. They tried to differentiate this decompression from other forms of traction. But as the president of our American Chiropractic Association down in, Dr. Glenn Manso says, as you said, it's just traction. And so it's just that traction has been inexpensive, and all of a sudden it became expensive and well marketed. but the research does not support what they're saying. And that requires you also, though, to be aware of the quality. You have to end up being a critical reviewer of the literature, which the public it shouldn't be expected to be, but they in the end still have to search out the issues. And so, you know, in the last chapter of my book, we talked about conflicts of interest in research, and this is a big problem, especially in the United States. Is that if, let's say that you're a person, you come up, you're a clinician, you come up with a new approach that you think is numerical, and then you form a company, you put it all together, and then you do your research, and lo and behold, it's fantastic. And what it is, though, is biased. And and so now we continue to try to put new strategies together, and more medical journals try to get conflict of interest statements to make sure that we don't have those types of conflicts, and it becomes more and more challenging. And my book showed in the last chapter that as time goes by, we continue to increase our standards for conflicts of interest, and we continue to lose this battle. So that means it's more problematic now than it used to be. And so you must, for the research, for example, when they talk about some of their success rates, you must understand that very often there's biased research out there showing these standards. But the fact is, you know, the ligaments in our body only have a very limited amount of stretch, about 4% stretch before the stretch is permanent. And so there's only so much you can do. And what you get is that you get benefit. I'm not saying you don't get benefit from decompression, as they call it. I say it's traction, and I said that it's always been known to be of benefit to some degree, traction, and it still is, but it's nothing more than traction, in my view.
Well,
Dr. Morris, I'll ask you a couple of questions as well. They both revolve around calcium. One is that somebody has a herniated L5 and they're wondering if large doses of calcium will help. And then also somebody else is wondering if there's any truth to the supposition that carbonated sodas can remove calcium from your bloodstream and bones.
Let's see. So the first question regarding the calcium.
Yeah, does calcium help if somebody's got a herniated disc?
I'm not aware of any research along that line, but there may be, but not that I'm aware of, and I don't routinely recommend that. So, but
and then does
maybe an area
carbonation
that I'm not aware of.
Okay, thank you. And then does carbonation remove calcium from your blood or your bones?
That's a good question, and I'm not familiar with research on that. I try to look to the research on this, although it wouldn't surprise me that it would. But well, because of the pH factors, just the carbonation, not the chemicals within it, but just the carbonation.
Yeah,
I don't know. I don't know. I think that there's more important factors with regard to calcium and within the bones. And a lot of people I hear, I have many patients who think that first of all, if they have osteoporosis, that they assume that that's painful, and that's not true. Osteoporosis is not a painful condition. It puts you at higher risk for fracture. Fracture is painful.
right.
But not the osteoporosis. A lot of people also become very worried if they get a bone density test, and it shows that their levels are low. And I'm not saying that should be ignored. I am saying that it's important to try to get, if you're going to get those, get a few in a row and go of the same company, the same machine, and see. Because what I find almost routinely is that a person that has as low 1 year is the same the next year and the next year. What I don't see is dramatic loss. What we should be doing is focusing on our activities. So you want calcium in your diet, and you want, but what you need is weight-bearing exercise. Walking is under-respected in its benefit, and it's what it is we are designed to do. But as you put loading, and as you load the bones, then that tends to stimulate the osteocytes and establish the calcium levels and keep the bones strong. So what you want is you want calcium in your body, but you also need exercise, weight-bearing types of exercise. And by the way, in the book we talk about it very clearly. We have now nice studies that have shown that humans in their 80s and in their 90s have had dramatic benefits in their functional capacity with resistive exercises, dramatic gains in strength. This is people in their 90s, mind you. I'm not saying that I'm not recommending that a person in their 80s and 90s recklessly go buy a large weight set. I am saying that you should consult with your doctors. You should be wise, but you should not use the idea that, well, you know what, I'm 80 years old, I'm getting old, so I really have to cut back on all my exercise and I'll sit around more. No, you listen to your body and you stay active and you do it tolerably and responsibly.
Right, absolutely. Now, speaking about your book, where would you recommend that people go to first? Is Amazon.com?
Yeah, Amazon.com. It's present there. There's another, OPTP, always keeps a good store. That's actually more of a clinician's website. And I think Amazon.com. I think McGraw-Hill also has a website where you can purchase it. So I'd say those two, Amazon.com and McGraw-Hill.
Okay. And it's called low back
syndromes.
Disorders.
Syndromes, then integrated clinical management.
Great. I have a question along nutrition. It says, do you believe that nutrition can play a major role in addressing back disorders rather than surgery or other invasive techniques? Are you an advocate of good nutrition as a path to healing lower back disorders?
I really am.
Yeah.
I really am. I both personally, I take a lot of supplements personally, and but that's not to say that you can't get a lot of a good nutrition just from your diet if you have a good diet, and especially with the use of organic foods and trying to keep the body as toxic free as possible. So I do actually recommend a lot of supplements, and it's critical for our proper function, nervous system, musculoskeletal system. It really is critical, and it can have an impact on inflammatory levels and pain levels. We talked about how it influences myofascial pain, and I see that quite a lot. A lot of patients are low in vitamin F, the essential fatty acids. So I always check my patients, their skin, to see if they're dry. If they tend towards dry skin, almost all of them that do tend to put topical things on to try to some sort of a moistener, instead of understanding that it comes from within that dryness and that they need more essential fatty acids if it's affecting their skin. It's generally affecting their nervous system and their musculoskeletal system, and also they very often has an effect on warding off infections. So I a lot of times will just recommend patients have raw mixed nuts or virgin olive oil or avocado in their diet, and add that, because there was a big push on cholesterol issues and fat issues about 15 years ago that I think did quite a lot of damage to our society. I think it was good marketing. They traded fats for sugar, and now all of a sudden we have another big increase in diabetics in our society. And I think that's attributable to that change, and people are worried about fat, and they came to the conclusion that fats are bad, and that's wrong. They never took into consideration, for example, that Eskimos that live on the land in Alaska have the highest fat consumption on the planet, eating raw blubber, and don't have cardiovascular complications. It's only when they go into the towns, into the cities, and starting eating cooked foods and cooked fats that then they start to take on the complications of cardiovascular problems that the rest of us, our societies, tend to have. So I don't think it's the fat. I think it's the way it's prepared. If it's raw, if it's natural, then I think we need that, and that we tend to be, as a society in the United States, we don't respect the importance of essential fatty acids, for example.
Absolutely.
Dr. Morris? David.
I was just going to say that we actually had someone come do a presentation on fatty acids for 2 hours, and we were just, I mean, it just brought out many of the things you're talking about, just how important these fatty acids are to our health.
That's right.
Yeah. Go ahead, Sherry.
One of the questions is, how can a nerve grow back? And I just want to tell you, I appreciated those pictures that you had on there about how the injections are into the nerves and stuff. My mom's had that done for years, and just that picture was like, oh, okay. Helped me understand something that she's been talking about for a long time. So the question is, how can a nerve grow back?
Well, there's different types of nerves, and some can grow back and some can't. So in the periphery, we have what we call Wallerian regeneration. So nerves in the periphery grow back. Unfortunately, they don't in our central nervous system and the spinal cord in those areas. So this is why people who tend to get cord traumas tend to have a permanent injury, whereas those who have peripheral traumas tend to recover.
Okay.
Just a couple more. What about degenerative disc disease? I asked the person to elaborate, and I think he or she says, do you have any suggestions for pain and or any type of healing suggestions outside of surgery?
I'm glad that's a good question. I'm glad it was brought up. I essentially reject the diagnosis. Professor Ed Nachemson, again, who I've mentioned now twice, I think, from Sweden, made it clear that he felt that the spine world was making up a diagnosis with this. He says, here's our problem. There's many times more degenerative discs that are painless than painful. So how do we go about defining it as a disease? So his feeling was it's as much of a disease as graying hair because it's part of the aging process, but we can't correlate the degenerative disc specifically with a disease and being a disease process. So instead, we're having to look farther into this topic. So what is going on? I said earlier that the disc can be a pain generator. We know there are pain sensors within the fibers, but that doesn't mean just because the problem with the degenerative disc being a disease process is it's viewable. We can see it. And so as a result, it was assumed that just as it degenerates, as it dehydrates, you saw the MRI earlier on with the disc herniation, in which you had 3 hydrated discs and 2 that were dehydrated and darker. And so, but the fact is, it doesn't correlate. So we can't. It's a diagnosis that you find depending on the specialty and how much they rely upon those issues and how much they're following the research. Whether they want to accept that or not, but the fact is, and so it's accepted in our society. But to me, I tell patients every day because and some are not happy because they've been given that diagnosis and they've learned to accept it and rely on it, and it's a bit of a helpless diagnosis, but it's also led us to a great number of spine fusions because of the degenerative disc disease, and spine fusion surgery is a tough topic. And the results are difficult. So I think that we can get tears in the disc, and that may be a pain generator. But is it worth treating or calling it? And what to do about it? We really don't know. We don't know what to do about this, and it may be that the best thing on some of these is to give them time and let them calm down and let it continue to degenerate. And the more it degenerates and dehydrates, that maybe then it will just start to fuse, the joint will stiffen, and just like some of the other things that start to change, that maybe the best thing to do is to not over-treat it, because people become stigmatized by that. They say, okay, well, I have a degenerative disc. Well, and I tell them, you know what? Me too, and I don't have any pain because I do have degenerative discs in my neck and in my back. And so unless somebody has to explain more to me for me to buy it, but at this point, I agree with Professor Nachemson.
I have someone here who said, thank you, in capital letters. This has been very informative. And we all agree. Thank you so much, Dr. Morris. Now, do you have any last words you want to share with us?
You know what? I would just really like to thank the listeners for their time, and I'd like to thank you and Sherry for giving me the opportunity to share the information. And I'm just hopeful that you can take this information and allow yourself to feel more empowered to take control of your life and your health, and to discuss and hold your clinicians accountable. And they must give you the time, and you have to make sure if they're prepared to answer your questions, and if they're the people you want to team up with. But to lead the way, don't be led.
Are you there?
I'm here.
Okay.
Don't be led.
I think that's a great point. That's a very good point. And we're actually having a lady doctor come speak. She's been coming for a couple of times. She'll be coming again. She's done it once, but just educating people on the medications, what questions to ask, and like you said, being partners with their doctors and not just passive participants, if at all. And so I think that's really important. But it also starts and begins with knowledge, and that's what you've been so good at bringing out concerning knowledge of the back and spinal disorders.
Well,
so again,
it's been my pleasure.
Thank you again. Thank you. Well, folks, this wraps it up, and we want to thank you for attending tonight. Look out for next week. The webinar's coming up next week, and I'm sure we'll be having Dr. Morris here again to do some more webinars for us in the near future. You all have a great weekend, and God bless.
Good night.
Good night.